You're with us on Prisoner of the Mind, a video podcast about mental health, mental illness, and suicide. The inspiration for this podcast was the death of my son, Gregory, by suicide in 2020. He was an autistic man with mental health issues. And today I have with me Professor Julian Troller, who's the chair at University of New South Wales of Mental Health and Intellectual Disability, and he's a researcher and clinician. And today we're going to talk about a study you did around medical schools and their curricular content around intellectual disability, which I believe from your study, I think across 14 medical schools, was 2.55 hours in total. That's it.
That's right, Jessica. It's an absolute pleasure to be with you on Prisoner of the Mind today. And I guess before I start, I just wanted to acknowledge the amazing way in which people with intellectual disability are supported by those around them, and acknowledge the huge health need of people with intellectual and developmental conditions in Australia that is really currently unmet. And this little bit of work that we did was auditing medical schools and nursing schools nationally. We were really fortunate to get funding from the New South Wales government to conduct that national work. And we found that in both the medical schools and the nursing schools, there was very little content related to people with intellectual disability across all aspects of the curriculum. There was very little compulsory content, and there was very little inclusion of people with intellectual disability as educators. And importantly, very little direct exposure in clinical settings to people with intellectual disability.
Now, I think in Australia we have about 750,000 people with intellectual disability. How and why are they at greater risk within their health?
It's a really good question. And when we think about that risk, we need to think about factors relating to the person themselves, factors relating to those around the person, and then the broader systems issues in health and disability care, and the broader policy and legislative issues that really direct our actions in this area. So starting with the person, firstly, we know that people with intellectual disability experience really substantial barriers to access to healthcare on a daily basis. Some of these, of course, relate to the difficulty a person may have communicating their health needs and interacting with what are quite complex health service systems. Some of them also relate to the tendency people with intellectual disability have to live in situations that are less optimal and less affluent, and so that access to healthcare may be more difficult. And also the access to information about living well and staying healthy may be less accessible to the person. We know that at an individual level, some people with intellectual disability are more vulnerable to certain medical conditions. A small proportion of those are related to the cause of the intellectual disability itself. A bigger problem is that people with intellectual disability have lack of access to good preventative healthcare. And we know that from some of our own work in primary care and great work done by other researchers and clinicians nationally and internationally. So there's some of the factors related to the person themselves. When we take a slightly broader view, we see that those around the person often lack the knowledge and skills to support that person's healthcare journey. So that we know many family carers may not have the skills or knowledge to support that journey well. And we know that many professionals lack the skills and confidence to do a good job and lack the clinical tools and the clinical care pathways to help the person access the healthcare they need. And then if we take an even broader perspective, we come to that services system, which is really currently not equipped, not adequately staffed to address the needs. And then at the policy and legislative level, we've struggled for many years to have people with intellectual and developmental disabilities specifically named in healthcare and disability policy so that they can be a focus of our healthcare system.
So the average lifespan of a person with disability is what?
Our work suggests that the life expectancy of a person with intellectual disability is about 27 years lower than that of the general population, so somewhere in the mid-50s. And our work shows that the proportion of avoidable deaths in this group is more than double that seen in the general population. And when we look at the deaths, they're deaths from causes that are very common in our broader society, but many of the risk factors are left unaddressed for people with intellectual disability, leading to these untimely deaths.
Can you give some examples of how a lack of medical training would put this population at risk? Can you give some like anecdotal scenarios?
Absolutely. The key to good education, I think, in this area is early exposure to a person with intellectual disability for the health professional and gaining confidence in that interaction so that I feel confident I can communicate effectively with a person with a disability, and I feel I can enable them to communicate their needs effectively to me. And one of the things that we see happening recurrently, particularly in emergency situations, is that doctors and nurses lack that capacity for engagement with the person directly, keeping them at the centre of their care, and they run the risk of, because they haven't been adequately trained, seeing the disability first before the person. And so if we call that overshadowing, where one issue dominates and we don't get to the core of the issue. How that can manifest is, if I explain it quite simply, if I was a person coming to an emergency department with an intellectual disability and I was distressed because I was in pain, my ability to communicate that pain may change because I'm distressed and agitated. And so when I present to the emergency department, I might manifest that distress in behaviour rather than in direct verbal or other communication about the nature of that pain. A doctor or a nurse might see that or understand that I have an intellectual disability, and may see the behaviour first and not understand the basis of that behaviour because they don't have the skills and background knowledge to do that. And so that's an example of diagnostic overshadowing. And so I may not get the depth of assessment I need, but I might in fact be presenting with a very urgent and pressing medical problem that, if unaddressed, would get worse and would maybe cause a very poor health outcome or even death. A simple example would be a gallbladder infection or appendicitis or a middle ear infection. And I'm aware of many examples of people who have been in just these very situations who haven't received the medical care they've needed and have had disastrous outcomes.
Yeah, it's terrible. I can think anecdotally with my son. I remember he had to have a review. I don't know why he needed to have a review of his status of having autism, because it's a developmental delay, but he did. And I took him to a GP, and the GP ran through the protocols, and just as we were leaving, he had forgotten to do a genital exam on my son. And he said, "Oh, I forgot," just pop up on the bed, drew the curtain round and reached his hand into my son's pants. And I heard my son say, "What are you doing? What are you doing? What are you doing?" And the doctor just simply said, "You have to trust me." Now, I think exchanges like that make a person with intellectual disability reluctant to actually seek help. If help is, invasive, or in the emergency room, potentially dominant, that the response is to be dominant rather than to extend their understanding, then they're going to, in a way, give up. And I certainly know from rereading the clinical notes of when my son was hospitalized twice, the people attending were well-meaning, and they acted within the protocols of what they'd been taught, but they were completely missing what was going on. They didn't understand the difference between autism and suicidality in an autistic person.
Absolutely.
And autism has a greatly higher rate of suicidality. It was like between 3 and 8% higher than the regular population. And he was sent out of the hospital within 6 hours after a very, lethal suicidal gesture.
So I think that what you point to is something really important, that the staff are well-meaning even without training. That most people who work in healthcare are strongly motivated by good intention and altruism, and they want to do a good job. And they feel very much that people with intellectual and other developmental conditions should be involved in healthcare and should have good access to good healthcare. So when we when we survey health professionals, they agree with us. But when we ask them, do they have the skills and the training to do the good job they want to? They don't. What we need to get to is a position where all healthcare staff are aware of how to adjust their practice to do the very things you were saying, to make sure they're able to prepare the person with disability to receive the healthcare that they need and to engage in that healthcare journey as a central stakeholder, not as someone to whom things are done. And that's where we need to get to.
Yeah, and a positive example of that was because my son was born in the United States, because they have a population of over 380 million, therefore the disability population is so much larger, and advocacy and research is greater in a way. When he was 4, he needed a lot of dental extractions, and they were geared to dealing with people with intellectual disability and developmental delay. And they took him all around the surgery. The nurse took him all around the surgery, and he could raise and lower the chair. They showed him all the instruments and how to use them on a big set of teeth. And by the time he needed to be sedated, he was fine. So it's, that bit of upfront treatment can help the patient relax and, surrender to the treatment.
Absolutely. So that's all about adjusting the approach to make sure the person's level of arousal is low enough for them to be able to engage. And that's a great example that you gave. I think that the wonderful thing in doing or educating health professionals about the adjustments that are needed in healthcare for certain groups is it assists every aspect of our healthcare, whether we're dealing with a person with intellectual disability or some other form of cognitive or sensory issue, for example, autistic people who may be accessing healthcare, those with cognitive disorders relating to dementia or head injury. So if we do this well, we equip our next generation of doctors and nurses with the right skills, attitudes, and approaches.
Is there any existing research about doctors' attitudes towards intellectual disability? I know there's a literature about mental illness, and unfortunately, there are quite negative attitudes. For instance, in the emergency room, patients are often seen to be attention seekers and so forth. Is there a similar negativity towards people with intellectual disability across the medical profession?
Interestingly, no. There isn't a signal in the data, the data that I'm aware of. When we've surveyed health staff, including future doctors and training doctors and health staff in our systems, most of them have a very positive attitude to inclusion in mainstream healthcare and want to be able to do that, but just feel they lack the skills and experience because of that lack of training that they've received in their nursing and medical schools as per the audits that we've done.
And how is this to be? I mean, I know that your ultimate goal is to teach this at the undergraduate level, so the attitudes are formed by the time people become specialists. Is there any way of kind of retroactively fitting this? I know, for instance, in psychology, psychologists aren't really that great with grief and current suicide prevention methods. And when I look at professional development opportunities, you have to quite sort of like sift through the availability to find something that's really pertinent and current. Do you think that there's any kind of way of retraining existing qualified medical people?
I think you're onto something very important, that there's an upskilling required of our existing workforce. And some of the ways to address that are, for example, in the public health sector, including mental health, is to include mandatory training to a certain standard for all direct clinical staff, so that everybody has an awareness of how to make the sorts of adjustments in healthcare that we've been talking about. As well, I think there's a need within the colleges, the medical colleges, to include some content in continuing professional medical education, and to include in the specialist training programs minimum content related to this area. So we've made some inroads in that. We know that there's some pressure now on agencies with the Disability Royal Commission findings being handed down later this year to address this issue, and some colleges are beginning to show that interest. For example, my own college, which is the Royal Australian and New Zealand College of Psychiatrists, has agreed to include some minimum content in the basic or foundational training for future psychiatrists. And there's notional support for the development of a specialist training certificate in intellectual and developmental disability mental health. And that would be obviously for a select few undertaking that specialist training, but nevertheless, it's a step forward. And other medical colleges are showing some interest and are developing programs as well.
Within your own university, has there been any effort to readdress the curricular deficits that you see?
Yes, there has. There's been a lot of willingness to do that. And in fact, one of the joys that I have is to partner with people with lived experience in developing and delivering educational material to medical students. People with lived experience are the experts. And I think this model is one that should be adopted universally. Another very positive step is that, together with other consortium members, we've recently been involved in a Commonwealth Government funded initiative to develop core capabilities for all future doctors, nurses, allied health professionals and dentists, to make sure that there is core content in every one of those medical, nursing, allied health and dental schools nationally. Though the initial capability framework that we've developed as a group has gone out to public consultation, and we're now in the stage of refining that content and then developing the teaching tools that will help embed that, should universities be willing, of course, in their core content. One of the challenges here is finding the space. These courses are incredibly crowded, and it's very difficult to find new space. So it's a matter of producing the tools that are so good that people will simply want to use them and embed them in different aspects of existing content where they're relevant. And I think doing so almost by stealth helps us get there.
In your paper, you mentioned that in 2007, Australia signed an agreement with the UN about the rights of people with disabilities. Would you say, based on your findings, we are currently out of alignment with that agreement?
Yes, the United Nations Convention on the Rights of Persons with Disabilities is an incredibly pivotal document that Australia has signed the treaty and also ratified the optional protocol, which means that as a nation, we have to report against the expectations of this UN convention. Now, when you hear what the lived experience of accessing healthcare and healthcare outcomes is for people with intellectual and other disabilities in Australia, you recognise that we're a long way from the aspirational goals in that United Nations Convention. The interim report of the Disability Royal Commission labelled this issue as one of systemic neglect in healthcare for people with cognitive disabilities. And the central groups there were those with intellectual disability and autistic people. So we clearly have a major gap on all of the available evidence that needs to be addressed. There are some steps to do so. So we have a new national roadmap relating to the healthcare of people with intellectual disability that is being implemented by our Commonwealth Department of Health. And we have a number of initiatives as part of that. But we also have, based on the previous Senate inquiry into autism, a new focus on healthcare of autistic people that is developing, and I know there are a lot of really good people working on that now.
And these can turn into policy and recommendations, but can they turn into law or some sort of legal requirement? Because these are great ideas.
Yes.
And I think that often there are great ideas floating around, but if we don't make them imperatives, they're just great ideas.
That's right. We need the funding to implement the changes that are needed. And I guess I would say, on reflection at the moment, relative to the need, the initiatives are modest. They are a start, and I think we're on a incremental journey. One of the key things that has been funded in recent Commonwealth budgets is a new National Centre of Excellence in Intellectual Disability Health. That I see as a vehicle to potentially accelerate change through sustained advocacy with government, sustained lobbying for better and improved services, and innovation in services, as well as providing healthcare professionals and disability professionals with the knowledge and skills they need through educational programs. But as you say, it's just a start. It's not the ultimate solution. We need much more investment in this area, because the gap, simply if you measure it in the tip of the iceberg statistics around mortality, is stark for people with intellectual disability and those on the autism spectrum. It's an absolute scandalous situation that needs an urgent solution.
From a bottom-up perspective, if you are a consumer of medical services, how could you influence that?
Very good question. One of the most powerful tools, I think, is self-advocacy. And so I think empowering people with disability to be strong agents and voices in their own healthcare, and empowering those who support them to access healthcare, to know their rights, and to have clear expectations about what their healthcare, how their healthcare should be addressed, and the attitudes and approaches providers should take, is really important. I have the delight of working with a lot of advocates who equip people with disability with these skills, and equip those around them and support those around them to do this well. There's nothing more powerful than having someone coming to you with these expectations clearly spelled out, to almost train and teach the health professional the right approach.
It's like you need a sort of a disability chaperone, because it's such a confusing, it's so overwhelming for a parent or a carer to deal with an issue that they may have never met before, and they don't know what's right in front of them. They don't know what's ahead of them. It's really hard to advocate when you don't know the terrain, and neither does the doctor. Yes,
so you need the tools to navigate that healthcare journey as a person supporting the person, as a family member or a carer, and as a person with disability, you need awareness of the pathway. If I could highlight one of the tools that we're just about to launch, in fact, is one related to the mental health care journey of people with intellectual disability. And this is a web tool that we developed, and it has a component for people with intellectual disability, for family members, for disability professionals, and for health professionals. And you can really enter that navigation tool at any stage of a mental health journey in seeking help and assessment and management of your mental health condition, and find the relevant tools and the troubleshoot how should this journey be optimised. And so we're trying to connect all of those stakeholders in a way that they can access the information if and when they need it. So that's an example of a tool that might help in that situation to empower people in that journey.
And if you have a link for that, I can put that in the information below.
We're about to announce the launch of that, and I'll send through a link, and I'd love you to include it. Thank you.
And while, you know, we're focusing here on medical professions, I suppose the lack of awareness about intellectual disability and disability in general probably comes from a cultural bias, which advocates called ableism. Can you speak to ableism a little bit, what it is? Yes. And what it does?
I think this is a profound societal influence where we view people with disability as other. And so the instant that we have that attitude and approach in our society, we lack the vision for inclusion of people with disability in all aspects. And we minimise the opportunity for engagement in life and in our community. And this also affects healthcare. So if we view people with disability as other and as less than citizens, we also view their rights to healthcare as different to the general population. So I think this cultural aspect and societal aspect is really key to shaping our broader societal attitudes that I think influence all of us, including future healthcare professionals and disability professionals, and families, as they somehow feel that maybe their loved one may not be entitled to the healthcare they need because our society views them as other. So I think it just permeates, and it's very important that we address that. I'm really confident that we've made a lot of progress in that ableism attitude in our society. I've seen that in my own lifetime. I remember attitudes to people who are different when I was at school, and I certainly recall attitudes of those around them, including people who are educating these young people, as being highly pejorative at that time. And now I think we're in a situation where our society has a greater awareness of difference. To some extent, there's a championing of that difference. So an awareness of the wonders of neurodiversity, for example, I think is just a wonderful approach to take. So recognising and valuing difference is what it takes to address this. But we've made some steps. I think I'm very positive.
We have a long way to go still. I'd say even from a curricular level, just from, say, gender discrimination as a child studying history, there was nothing really about the lives of women, or some exceptional women who tended to be high up in society. And so we still need literature and social studies and all sorts of examples that are inclusive, because I think people with disabilities don't see themselves on the pages yet.
Yes.
And I think that that's an important thing. I went to a workshop, it was a long time ago now, but this was through architecture. And there was an architect who talked about these modifiable houses, that all houses should be built to be modifiable. So kitchens can be lowered, all stairs could be ramped. Because by the time anybody reaches the age of 90, 90% of 90-year-olds are going to be disabled, not necessarily intellectually disabled, but possibly. And so if you live long enough, it will happen to you.
Yeah, so the concept of universal design is one that has gained a lot of traction and influence in the built environment. We don't embrace that concept as we should in healthcare. So if we're thinking about universal design meaning accessible healthcare, we make sure this underpins all of our developments. And so that's been very much a construct behind my push and the push of many other people to make sure that people with intellectual and other disabilities are included in, for example, healthcare policy and all aspects of innovation and healthcare service development, and then all aspects of execution of a health service, including those with lived experience as peer workers in the workforce. So if we were doing universal design well in a healthcare context, we do all of those things, I think, to make sure that our healthcare system was accessible to anybody, including those with cognitive disabilities.
Yeah, and I can think of things like often you're given literature or pamphlets when you go to the doctor to have that done as a graphic novel.
Absolutely.
Something visual.
Yes, and there's very little information within our healthcare systems that is information that is adjusted for different communication needs. We had the pleasure of developing some within a mental health context for people with intellectual disability, and designing a toolkit to enable healthcare practitioners to produce easy read material themselves where they needed to in their clinical practice. But that's the sort of thing that I think we need to have happen universally.
The work continues, doesn't it? And so, you're going to have a career where you're going to never run out of things to do. It'll be ongoing, won't it?
It's an absolute privilege to work in this area. The need is just enormous, and the future, I think, for people working in this area is very bright. So I would encourage people to be thinking about how they could contribute in this area, whether you're a healthcare professional, a disability professional with a passion for good healthcare, whether you're a family member, whether you're a person with disability. I think together we can make a difference, but it takes a lot of time, it takes a lot of energy, it takes a lot of investment by government, and I think we need to keep fighting for the investment in proportion to the need.
Right. Well, Professor Troller, I'm so grateful that you gave up your valuable time to speak with me today. And if you're with us and you're watching and you're struggling, I want you to know that I believe you. And in the words of my son, Gregory, I want you to know that you matter.